My name is Bill Hogan. I'm the interim dean of the College of Health, and I want to thank all of you for coming. And again, I apologize for not starting on time and, at least at this point, not having the audio-visual option for us. So we have a discussion this evening about adverse childhood experiences, and we're grateful to have Dr. Rob Anda, who is one of the principal investigators with the Adverse Childhood Experience study that was conducted with the Centers for Disease Control and Prevention in Kaiser Permanente in Southern California back in the 90s. So he is the expert. He and Dr. Vincent Felitti, one of the other co-principal investigator on adverse childhood experience. So the way we're going to structure the evening is we're going to have Dr. Anda talk about ACEs in general, do an overview, talk a little bit about practical approaches to addressing ACEs. We want him to highlight maybe some interdisciplinary things that he's seen in other states. Then we're going to have Dr. David Driscoll with the Institute for Circumpolar Health Study talk a little bit about what's going on in Alaska. And then finally, Elizabeth Ripley, who is the CEO of the Matsu Health Foundation, is going to talk about ACEs from a funding perspective, particularly a philanthropic funding perspective. And then we'll open up questions or give people in the audience a chance to ask some questions. So we are hoping we can still make this work or still fix this so that you'll be able to see what Dr. Anda is talking about. Because I know it would be easier, particularly when you get to graphs and stuff, right? Let me also, I want to thank our sponsors, the Institute for Circumpolar Health Studies, the Justice Center, the School of Social Work, the Department of Health Sciences, and finally the College of Health for tonight's presentation and discussion. So without further ado, Dr. Rob Anda.
Thank you. Can you hear me okay? Let me just give you a little bit about my background and how I got into this field. My training is in internal medicine, and the things that I saw in internal medicine saw a lot of difficult things. The experience that I had at the Veterans Hospital in Madison, Wisconsin really had a great influence on me. This was between 1979 and 1982. Saw a lot of World War II veterans. Saw a lot of men dying of smoking-related illnesses, chronic lung disease, lung cancers, alcohol-related diseases. There was a lot of mental illness. And that was at a time before we really knew about the term post-traumatic stress disorder. And so I saw a lot of things that I really think didn't need to be there, and I wondered why some of these men behaved the way they did. For example, there was a man that I remember, a guy named Ed Berry, who had severe chronic obstructive pulmonary disease. And for Ed, getting up from his bed and going to the sink to brush his teeth was a near-death experience. He would be at the sink just, it would take him 5 or 10 minutes to recover and get back to his bed. And what Ed would do is after he would take his wheelchair down to the smoking room and take out his nasal cannula and smoke cigarettes and tell stories about World War II with his friends. And we saw a lot of men like that, and so I wondered what was behind those kind of behaviors. At the university hospital, I saw a lot of people with end-stage cancers and heart disease, things that didn't need to be there if proper prevention efforts had been available. I spent some time working in the Wisconsin prison systems. And I wondered what these young men, and this was in central Wisconsin, what these young farm boys, mostly young farm boys, were doing in these prison systems and how they got there. And finally, I did some work in emergency rooms in Wisconsin. And if you've ever been in an emergency room on the weekend, I did weekend shifts. If you've been in the emergency room on weekends, you'll see that most of what happens is alcohol and violence related. So I decided to pursue a career in preventive medicine and epidemiology, and ended up spending about 10 years at the Centers for Disease Control looking at risk factors for chronic diseases, mostly cardiovascular disease. And after about 10 years of doing that, I became kind of disillusioned that we were looking at things, risk factors for disease and disability and social problems that were entrenched and that you can treat and you can modify, but it's difficult to change behavior. It's difficult to get people to stop smoking. The treatment of hypertension, the treatment of obesity and diabetes are useful, but they're difficult and expensive. So I decided to look at some of the emotional origins of disease. One of the things that we looked at was getting back to the idea of why people smoke even when they have serious terminal illnesses, is we began to look at, in national studies, at emotion. So we did a study of the relationship between depression and smoking in a national study, and found out that the more and more depressive symptoms people have, the more and more likely they are to smoke. And when you follow those people over multiple years, you find that the depressed people are less likely to quit over a multi-year period. And so what we began to talk about is the self-medication hypothesis around some of these behaviors, and that nicotine in cigarettes is an antidepressant. And so part of the explanation for some of these behaviors is that people are self-medicating underlying emotional problems. In 1991, I met Dr. Vincent Folletti from the Kaiser Health Plan. He came to the CDC and did a brown bag seminar. I think about 8 people showed up for the seminar, and he came and presented results from a weight loss clinic. He had a very large preventive medicine department there, and what he had discovered is that there were certain women who would lose a great deal of weight, 150 pounds, 160 pounds, and then would disappear from his program, or they would quickly regain their weight. He has some charts where he shows weight loss over a period of weeks, and then incredible rapid weight gain. And he wondered what was wrong with his program. So he sat down with some of these women that appeared to be failing in the weight loss program and did open, unstructured interviews. And over a period of 2 weeks, he heard multiple stories about childhood sexual abuse from these women. And as he told me at the seminar, he said, he's a couple years older than me, he said, I've been practicing internal medicine for 25 years, and I've never heard anybody tell me that they'd been sexually abused. Now in 1 week, I've heard it 4 times. So he did a case control study looking at the relationship between childhood sexual abuse and obesity, and saw that women who had been sexually abused as children were much more likely to be severely obese. And so he brought this result to the Centers for Disease Control, and with some of my interest and other people's interest in the origins of health behaviors, we decided to design the Adverse Childhood Experiences study. By way of background at that time, that was in the early 1990s. I had never even thought about child abuse before. I spent about 6 months in the afternoons doing Medline searches. I did a search under the mesh heading child abuse and neglect, and I went back 15 years, and I scanned every abstract under that mesh heading, going back year after year. I didn't read the articles, I just read the abstracts. And what I saw after doing that, after a few months, is that the field of child abuse and neglect and the health consequences was really a kind of a scattered kind of discipline. Most of the studies had looked at one form of child abuse, usually sexual abuse. Some of them had looked at physical abuse. A few were starting to look at the effects of childhood exposure to domestic violence, but they all looked at these exposures singly, and the kind of outcomes related to those childhood experiences were fairly limited at that time, mostly related to depressive symptoms and psychological measures. And so what I imagine that this whole field was sort of like a bucket full of BBs. I imagine a bucket full of BBs that needed to be pulled together, where there was fragmented pieces of information. So what we did with the ACE study is we decided to look more broadly at different types of childhood experiences. So we took 10 categories of childhood experiences that we call adverse childhood experiences. And those 10 categories were 3 forms of abuse: emotional, physical, or sexual abuse; 2 forms of neglect, emotional or physical neglect; and under the heading of what we called household dysfunction, there was witnessing domestic violence, growing up in a home, witnessing domestic violence, growing up with substance abusing or mentally ill household members, parental separation or divorce, or having someone in your household sent to prison. We did the study in San Diego at the Department of Preventive Medicine among 17,000 people in the health plan. What you need to know about these 17,000 people is these people are mostly middle class, upper middle class people who've been to college, mostly white. And what we found is when we look at these 10 categories of experience is that they were really common. Exposure to childhood abuse was really common. About 15 or 16% of them had been emotionally abused. 20% had been sexually abused. It was about 26% for the women, about 15% for the men, and almost 30% had been physically abused. Other common adverse childhood experience exposures were growing up with substance abusing or mentally ill household members, about 25 or 30%. So what we saw is these 10 categories of adversity were really common even in an educated upper middle class community. So ACEs, these 10 categories of ACEs are common. The next thing that we saw...
Can I stop you just a second,
Yeah.
Rob? So if you can come this way and bring the microphone this way, this gentleman is
Okay.
going to try to work on this.
Oh, good.
Hopefully
Okay.
it's not too disruptive.
Okay. We saw that these 10 categories of experience were highly interrelated. What was different about the way we designed this study is by studying 10 categories of childhood exposures, we were able to show that how they were related to each other. In the past, they had been looked at singly. So what we saw is that where there was one type of adversity, there was usually another. And the example that I like to use is for people that grew up witnessing domestic violence. That's one type of adversity, or stressor that they were exposed to. If you had experienced that particular stressor, 95% of the time, you would have experienced one of the 9 other types of adverse childhood experience. So these types of experiences tend to co-occur. They tend to co-occur. The way that we dealt with that, there's 10 of them, since they're so co-occurring, is we created an adverse childhood experiences score. From 0 to 10, we added up the number of categories of childhood experiences that these people had had from 0 to 10. And I think of that score as a biologic stress dose. And I'm going to take a few minutes to talk about what I mean by that. In early childhood development, brain development is sequential. And these stressors, what these stressors do is when we're stressed, we have adrenaline and cortisol released from our adrenal glands. The cortisol that's released from our adrenal glands is toxic to developing neural networks. It makes it difficult for the nerve cells to make connections. And the adrenaline is a neurotransmitter that confuses developing neural networks. So if you think about being exposed to 1, 2, 3, 4, or 5 or more types of adversity, you were exposed growing up to more and more adrenaline and cortisol, which makes it difficult for your neural networks to develop as a child. That results in difficulty regulating emotion, calming yourself down, a higher likelihood of being anxious or depressed, or thinking clearly. So what we did is we took the score and we looked at that ACE score as it relates to a lot of different health and social problems. And for almost all of the major health and social problems, public health problems that we looked at, we saw that as the ACE score goes up, the chances of all of these behaviors and health problems went up in a graded stepwise fashion. So for example, with smoking, the probability of being a current smoker for people with low ACE scores to high ACE scores is about 5 times higher. And then we looked at lung disease, which is related to the smoking, and saw that the probability of lung disease, which is usually diagnosed late in life, goes up 2 or 3-fold as the ACE score goes up. So there's this developmental pathway of early childhood experience leading to high levels of adrenaline and cortisol affecting brain function that leads to behaviors, compensatory behaviors like smoking, that in turn are pathways to disease. We saw the same kind of graded relationship to many things that we looked at, to teen pregnancy, to having multiple sexual partners, to lung disease, to lung cancer, to heart disease. The probability of having heart disease is higher in adulthood as the ACE score gets higher and higher. Social problems, relational problems, domestic violence. The chances of growing up and having an intimate partner that treats you violently goes up in dose-response fashion with the ACE score. The probability of being sexually assaulted when you grow up for both men and women goes up as the ACE score goes up. And so we saw for so many things that we looked at, and we don't have the bar graphs here, so I'm going to summarize and tell you that there's many things, many major health and social problems, reproductive health, teenage health, autoimmune diseases, chronic lung disease, liver disease, dying young. People with higher ACE scores are more likely to die early than people with low ACE scores, up to 20 years earlier for high ACE scores. In public health, we do a calculation called population attributable risk, which is an estimation of the proportion of a problem that's caused by an exposure. In this case, the exposure is adverse childhood experiences. And what we saw for things like alcoholism, we estimate that almost 2/3 of alcoholism has its origins in adverse childhood experiences. About 80% of shooting up drugs, half of depression, half of domestic violence, almost 2/3 of sexual assaults appear to have their origins in the neurobiologic consequences of adverse childhood experiences. So where this leads us is that this is a pathway, this is a major pathway to prevention. By preventing adverse childhood experiences, we have the opportunity to prevent many of the major health and social problems of our time. And I'm not sure where to go from here in terms of talking about the ACE study. It calls for interdisciplinary approaches to prevention. All of the fields, both the exposures, there tends to be a different field for the prevention of each of the types of childhood adversity. Domestic violence has its own prevention field. Sexual assault, child abuse, neglect, treating substance abuse, and mental health problems are all separate fields that are treated differently, that are ACE exposures. And then, of course, all of the different types of outcomes. There's a field for the prevention of heart disease and a field for the prevention of sexually transmitted disease and teen pregnancy. So what this study ended up really calling for is an integrated approach, a systems approach to the prevention of adverse childhood experiences, as well as the wide array of outcomes that it's related to.
Okay.
No?
You want to?
Sorry, can I get you to log in?
This is not our computer, so I'm not sure where Barbara. Can you log in here, Barbara?
We're going to try to log in. At this point, since I don't have my slideshow, does anybody have any questions about what adverse childhood experiences are or how we did this study? Go ahead, yeah.
Absolutely.
Excuse me, Alan Barnes from the Justice Center, and you mentioned a number of things that, of course, are criminal in nature by themselves, but I was wondering if, since justice and crime would be of more concern to me, did you see other types of criminal behavior in general as a product of early childhood experience?
We didn't look at criminal behaviors per se. We asked people if they had been perpetrators of intimate partner violence, and we saw that as the ACE scores, childhood ACE scores went up, that the probability of growing up and treating your intimate partner violently went up. We didn't design it as a study of crime, but in terms of intimate partner or domestic violence, appears to be a cause of intimate partner violence.
You mentioned that these experiences put you at greater risk for experiencing domestic violence and some of these things, being the victim of some of these things. That's why I was asking the other side about being the perpetrator.
Perpetration is harder to study because, you know, it's hard to ask people in a health clinic if they've perpetrated crimes. So we don't know about that. I believe there's other literature showing that suggests that being a victim leads to perpetration. And again, the only clue that we had was perpetration of domestic violence. Anybody else?
Tanya Bennett, I'm a student here. Welcome to Anchorage. I was curious about the age group you were looking at. Now, I understood that you said you're in the middle class, but my actual thought process is that perhaps you found a difference in the ages and the responses, potentially from people whose parents would have been older versus...
So you're asking, does the age at which the experience occurred make a difference?
No, the age of your sample. The age
Oh, the age of the sample. Okay.
Right.
Yeah, the age of the sample was 19 to 94 years. We actually did birth cohort work where we divided the people into different age groups. And it doesn't look like when you were born or how old you were at the time of the survey made a difference in terms of how adverse childhood experiences influence the risk of all these outcomes. So when you were born doesn't appear to make a difference. Anybody else? Yeah.
Has any of your work looked at historical trauma among indigenous people?
Actually, no. Historical trauma is something that I think needs to be looked at in the context of how it relates to the kind of traumatic experiences that we talked about in this study. You know, how historical trauma leads to this kind of more kind of household intrafamilial kind of trauma, as well as structural problems in society, community violence, in inner cities, structural trauma being incarceration of large portions of populations. But I can tell you that in this particular study, there weren't very many Native Americans or people from tribal communities in the sample, but it was the one group that had by far the highest ACE scores. The ACE scores, the trauma histories didn't vary that much between Caucasians or Hispanics or African Americans, but they were much higher in the Native Americans in the sample. And the lowest scores were among people who said they were of Asian descent. They were substantially lower. Anybody else?
I wonder if you could talk some about your work in the state of Washington and some of the things that they've done there.
Okay. What the state of Washington did about 10 years ago is they took this information about adverse childhood experiences being a leading determinant of health and social problems, and what had been learned about the neurobiology of stress, how these kind of stressors affect brain development. And the leaders of a group called the Washington Family Policy Council decided to take this to their community networks. They had 24 different communities that they were doing prevention activities with. And those communities had picked really good things to work on. They funded the communities and allowed the communities to decide what they wanted to work on. So in these 24 communities, there was a wide array of things that they were looking at. For example, domestic violence, preventing domestic violence, or sexual assault, or teen pregnancy, or suicide. And then when they saw the data from the ACE study showing that all of those different types of health and social problems tend to have a common biologic origin in the effects of stress on the developing brain, what they did is they came back and said, what we need to do is we need to go to our community networks and have them learn about sequential neurobiology and the effect of stress on the developing brain and how that leads to all of those different kind of problems in their communities. And so they spent about 8 years doing conferences, community meetings like this one, and really educated the entire state about adverse childhood experiences and how it leads to common health and social problems. And now they have communities where they're trying to do something about this. In Pierce County, Washington, for example, there's a researcher who looked at adverse childhood experiences on kids in parole. And as you would expect, kids on parole had really high ACE scores, but as their ACE scores go up, their chances of not doing well when they're on parole or on probation, their chances of not doing well go up. Their grade point averages in school get lower and lower as their ACE scores go up. Their chances of abusing alcohol and drugs go up. And their chance of felony reoffense goes up as their ACE score goes up. And so that would be an example of translating the work that we did into community action. So knowing that, what they did is they started to educate judges. In fact, we did presentations for some of the judges in Pierce County and the probation and parole officers to begin to understand that in order to keep these kids out of the criminal justice system, you need to deal with the effects of traumatic stress, which is the pathway that led them into the justice system. Their use of alcohol and drugs, their failing in school, the behavioral problems that lead them to be suspended or expelled, and to go out into the community and do the kind of things that got them in contact with the justice system to begin with. Another example, a recent example, is at an alternative school in Walla Walla, Washington, that took this information, decided to try to understand the nature of some of the behaviors that these kids have that got them into an alternative school. And there's this idea called being trauma-informed. Anybody heard of being trauma-informed care? Anybody? Somebody want to say what they think trauma-informed care is?
It's designing service systems, or that's one aspect of it, coming from a trauma-informed point of view, so an educated point of view about trauma theory.
Okay. All right. That's pretty good. Would you like to come to the microphone? So the simple, I'm just beginning to learn about trauma-informed care. The way I think of trauma-informed care, the way it's been framed for me, is that it takes some of these behaviors, like mental health problems, substance abuse problems, maybe even criminal behavior, and changes the question that we ask people when we see them with those problems from what's wrong with you to what happened to you. And it takes the shame and blame off of these things that are the natural biologic consequences of exposure to adverse childhood experiences. And it changes the nature of relationships that people have with clients. So in Walla Walla, Washington, in this alternative school, the principal of the school and the whole community had been informed about how adverse childhood experiences affect health and behavior.
Digital login? Or this isn't yours, is it?
And by doing that, understanding that these kids have, for example, difficulty regulating their anger or their emotion, is that rather than treating angry outbursts by the students with suspension or expulsion, is they basically would put them in timeout, say, or why are you acting that way? And kids might say something like, well, one of the kids said, my dad was taken away by the SWAT team last night. And so he's acting out in school, and what they did through this process of understanding how kids react to trauma and how they have difficulty regulating their emotions is they reduced suspensions and expulsions from school, I believe, by about 80%. And so that's an example of using this kind of information to change policies and practice in public institutions, like the correction system and the K-12 public school system. Yeah.
Have you looked at the intergenerational effects? And I'm particularly interested in maybe any epigenetic influences.
Okay. Could you repeat that for me?
The question, Jim, maybe if you could stand up.
Yeah, I'm wondering about intergenerational effects.
Intergenerational.
And I'm particularly interested in any epigenetic influences.
Yeah, I think the most important part of thinking about preventing these kind of adverse childhood experiences is that they are intergenerational. People that are exposed to abuse and neglect and substance abuse and violence tend to grow up and be people that take on those same kind of behaviors. So there's that kind of intergenerational aspect. Epigenetics, my personal belief is that epigenetics probably plays a large role in why these relationships are so powerful. Is that, who here, does anybody here not know or not heard of epigenetics? Let me tell you about it. Okay.
You probably should explain it.
All right. The way that I think about epigenetics is all of our cells have the same genetic code in them. So if you take, say, a skin cell, on the tip of your nose, you take a kidney cell, it's all the same genetic code, right? It's how the genetic code is read, and when it's read determines how a cell functions. So that's epigenetic control. The reading or not reading, or the sequence of reading the genetic code, determines how a cell functions, what it looks like and how it functions. There are studies in animals that show that how animals are reared determines how the next generation rears its own babies, and that the way the babies, that's passed on through the way the genetic code is read from generation to generation, not through mutations. We tend to think of genetics as mutations, changes in the way, in the coding sequence, but in rat studies, it's through the parenting behaviors are passed from generation to generation through the way genes are expressed, the way the parenting genes are turned on and turned off. Anybody else? Yeah.
Did there appear to be a technique that seemed to ameliorate the effects of these adverse childhood experiences more than others?
At this point, I don't think that there's any like really earth-shattering types of things that would have huge public health impact. Cognitive behavioral therapy, and I'm not a therapist, but if somebody else wants to talk about therapy, cognitive behavioral therapy, a technique called EMDR. If you think about it, if you've heard of that, where people are asked to recall in a safe place with a therapist to recall the traumatic experiences, and the therapist moves a finger back and forth and has the patient follow with their eyes. There's something about the tracking, the eyes moving back and forth and recalling the memories that can reduce the intensity of the emotional response and the memories around trauma. Those are two that I know of in terms of treatment in clinical settings. Anybody here work with trauma? Treat people that have been exposed to abuse or neglect and wants to talk about, answer the question, what works?
Sort of getting off into the future and segueing for playing into epigenetic.
Hey, Mark, can you stand up so we can hear you?
Yeah, there are a couple pharmacological approaches that are very experimental, and one is using medication that actually reduces or deletes the epigenetic marks associated with trauma. And this is something that's being studied in animals at this point. There's also an interest in actually using inhaled oxytocin, which is a pro-social hormone that is, the molecule is so small that you can inhale it. And in studies, now often they use college students for these studies, that the students that are in the inhaled oxytocin group are tending to be more trustworthy in games than those who don't. But there's some thought that using oxytocin might trustworthy.
I was going to ask a similar question, just with your smoking example and self-medication for depression. Is there any evidence at this point that just antidepressants can offset the risk associated with mortality and morbidity for these adverse experiences? Just as one example, just antidepressants.
So the question is,
once you have a high ACE score,
yeah.
are you just SOL at that point, or can you have an intervention such as an antidepressant, maybe, or something else that would tend to offset your likelihood of early death?
Well, antidepressants are commonly used in people that are traumatized. I think a question that's coming up now that I see in people that are working with victims of childhood trauma is that the treatments, the standard treatments and the pharmacologic treatments for things like depression may not work as well, that they may be more resistant to treatment. And the idea there is that depression in traumatized people may actually be sort of a different illness, in that the way the brain works is different in a traumatized brain than a non-traumatized brain, and that the symptoms of depression can look the same, but the way the brain is functioning is different. So So I'm not sure whether treatment with antidepressants actually, I mean, antidepressants has been used as an augmentation to trying to help people quit smoking, but I don't see it as a main way of getting out of these kind of behavioral pathways that are adaptations to trauma. Yeah.
I'm wondering if there's any communities that have found creative, effective ways to prevent the childhood adverse experiences. You know, I mean, we have, all communities have protective services, but I'm just wondering if, you know, if there have been like more positive, kind of resource-oriented interventions that have prevented.
You know, in terms of community-wide evidence, that community-wide work reduces abuse or neglect or adverse childhood experiences. There's really early evidence out of the state of Washington where they have summary measures of community capacity from all their different kinds of databases, community health, looking at all their different indicators of community health.
Yeah.
They have information from their surveys about the proportion of people that have different adverse childhood experiences for those communities. And it looks as though the communities that are the healthiest, that have the most capacity or the inverse, the least number of community problems, the younger people in those communities tend to have lower exposures to adverse childhood experiences. So this has generated a lot of interest in the idea of community engagement and community capacity building as a protective factor for kids and families in terms of the intergenerational transmission of the experiences. Yeah.
We've got several more. Let me publicly announce that this is not going to work. So we can stop trying. I know.
That's all right. We're doing all right.
So we'll go ahead.
Yeah.
Continue to take
Go ahead.
questions. Go ahead.
When you consider that all development happens in the context of relationships, there's, and I work with very young children and their families.
Yeah, this, I wish we had a microphone, but we don't.
When you consider that all development happens in the context of relationships, I work with very young children, and we are desperately trying to bring some interventions to work within the relationships of parents and their children, very young children, who really display these, I mean, I can point out the people who have high ACE scores, you know, just from their history. And I really believe that child-parent psychotherapy, where there's an intervention within that relationship of the parent and child, is really, I mean, if we want to, you know, when I think about interventions, I keep going younger and younger and younger and younger and younger. And we don't develop our workforce in being able to treat very young children and their parents and that relationship, then it just gets harder and harder and harder.
Yeah, you might be interested in the work of Dr. Bruce Perry from the Child Trauma Academy. He does some really incredible work with kids that have just been raised under the most difficult circumstances. And what he and his team are starting to do now is, they call it functional brain mapping. Have you seen his presentations? They call it functional brain mapping. And what they do is they have a team of people that evaluate the kids and look at their various behaviors and capabilities, and things like attachment, the ability to have a relationship with another person is one type of brain function. Hyperarousal, the tendency to be hyperaroused, is another, which tends to be lower in the brainstem. And the idea, as I understand his work, is that to find the critical pathway when in the stage of sequential neurodevelopment in the brain that these experiences occur, and where is the greatest developmental problem, so that in treatment you don't do global treatment and throw everything at the kids. You try to get at stimulating them in ways where the developmental problem really lies, whether it's attachment or hyperarousal. And so his belief is that doing that kind of work may be more effective than some of the more global kinds of treatments. And he says the same thing that you do, is that it's all about relationships.
I'm really saying the same thing that he said.
Yeah, okay.
I wish he was saying that.
Yeah, yeah.
You gave the impression that there might have been some consistent and constant relationship, say from 1 to 2 to 3 to 4 up to 10. But were there potential cutoffs for certain types of problems that would be certainly strong enough for you to mention? Because I am assuming that many of us probably have 1 or 2, 3, 4, 5, or whatever, and at some point that may be a tipping point for some of these experiences you were talking about.
In terms of how the experiences relate to the risk of different outcomes? No, I think almost universally what we see is a sort of staircase effect as the ACE scores, the number of categories of ACEs goes up from 0 to 1 all the way up to 8 or 10, is the risks of disorders and problems just keeps going up and up. And at the high ends, for some of the things, it looks like it almost goes exponential. For some of the things like for example, suicide attempts or intravenous drug abuse. So it doesn't look like there's a saturation or cut point for most of the things that we took a look at. It just more keeps making it worse. The risks go higher and higher. And even the difference, I mean, you see the difference even between 0 ACE and 1 ACE. You consistently see that just 1 ACE increases the risk of a lot of problems by 30 or 40 or 50%. Yeah.
Just talk about the idea of risk, and related to that, I'm wondering if you looked at people who had high ACE scores but had optimal health, so who didn't develop in this linear fashion.
Yeah. That's a really interesting area. Let's take a specific example. Say intravenous drug abuse. Okay, people with an ACE score of 0, the percentage of people who have none of the ACEs, who've ever taken a needle and syringe and shot up, is almost 0. It's almost 0%. For those with the highest ACE scores, it's 4%. Okay, so the risk for high ACE scores versus low ACE scores is really high. So even though it's only 4% in a high ACE exposure group, the risk compared to the low ACE group is increased by about 40 or 50 fold. So if you have a high ACE score and you don't shoot up drugs, does that mean, and people talk about resilience, does that mean that those people were not affected by their ACEs? And I would say to you that the answer to that is no, because most people, intravenous drug abuse is not a common phenomenon. The other aspect of this is that ACEs lead to so many different kinds of health and social problems that when you add up many of the different kinds of problems that we look at, you see that as the ACE score goes up, the chances of having multiple health and social problems goes up. So the idea of trying to sort out people who have high levels of childhood trauma or adversity and why they don't have a problem becomes difficult because it causes so many problems. Does that make sense? So I really what's needed next is a study that looks at multiple types of childhood trauma, multiple outcomes, and multiple protective factors to be able to sort out whether the protective factors blunt the chances of having a wide array of outcomes. But I think we need to be careful about calling people resilient or immune, so to speak, to adversity, because if they have a high ACE score and they don't have any single type of outcome, then we need to be careful with that because it causes so many different kinds of problems. We need to look at the universe of problems that adverse childhood experience causes. Yeah.
Getting back to the intergenerational question, I think it's pretty clear that kids who are exposed to childhood trauma have parents who have behavioral problems, as a rule. Those behavioral problems in the parents may actually be due to genetic risk factors, not just epigenetics. Mm. And so these children inherit both the theoretical genetic predisposition and the environmental exposure. Have you been able to separate those? Have you been able to rule out the possibility that these kids are inheriting genes that predispose them to behavioral problems?
Yeah, that's a really good question, and it's really interesting. It's a difficult question. I think, of course,
I mean, you could design an experiment where you would randomly assign kids to different environmental.
Yeah, that'd
Maybe we're doing it.
I think that kind of terrible work is done in the past by people that we don't want to think about. But the idea, of course, there are genetic factors, mutations, that play a role in who has what kind of outcome and that play a role in behavior. The way that I think about this, though, for example, geneticists talk about heritability. You know, what is the heritability of something like depression in terms of the genetic heritability through changes in the DNA code? And the numbers that I've seen are, 30 to 50%. I don't know if you've seen those kind of numbers.
Most behaviors seem to be about 50% genetically determined.
Yeah. So of course there's genetic things that are genetically fixed from generation to generation. But when you start taking a look at this wide array of so many things that have this strong graded relationship to childhood experience, I think for me it sort of strains credibility that somehow there's a gene, a mutation or a heritable alteration in DNA code that leads to so many of these health and social problems. One thing that we did do in terms of looking at how ACEs influence the risk of alcoholism is we took people who had a family history of alcoholism out of our database and then looked at all of the other ACEs, okay? And their probability of alcoholism goes up in a stepwise fashion as the adverse childhood experiences go up. So in a sense you're controlling for the genetic mutation heritage, those type of mutations that lead to alcoholism, by taking those out. And you still see this very strong graded relationship. You see the same thing for mental illness. When you take people who don't have a family history of mental illness out and look at the other experiences, you see that there's this experiential contribution. I think the argument, it's not nature versus nurture anymore, it's always both. And probably there are instances in which the experience and the mutations tend to come together and inflate the risk of the kind of outcomes that lie in the mutation itself. But clearly experience is a major determinant of a lot of these health and social problems. That's not to exclude the genetic heritage, but the experiential effects on the developing brain, I think, explain a lot of it as well.
So let's take two more questions for Dr. Anda, and then we'll have Dr. Driscoll and Elizabeth talk a little bit. Will that work?
Okay. Mm-hmm.
Okay.
Comment on that. There's a terrific article in Brain and Behavioral Sciences by Evan Charney, who is basically it's showing how all the foundations, the key assumptions of behavioral genetics are essentially crumbling as we understand the complexity of the genome, everything from epigenetic changes to retrotransposons and so forth. So the key assumptions that underlie some of these estimates, 50%, et cetera, are starting to crumble under increased understanding of the genome. Evan Charney, Behavioral Brain Sciences, in the last 2 or 3 months.
I think that's a good point. It's something that I don't have the answer to that I've thought about, is that if epigenetic changes are stable in meiosis, meiosis is when sperm and eggs are formed. If epigenetic changes are stable in meiosis, then when we reproduce, those changes can be passed on to the next generation. And I think that's probably what Charney is saying, is that it can look like a fixed thing in the DNA code when in fact it's the experiential effects on the reading of the genome that are stable when we reproduce, such that it looks like it's genetic in the sense of genetic mutations. Is that what he's saying?
That's right. And genome-wide association studies are showing almost nothing in terms of predicting depression. But looking at hundreds and hundreds of genes. So it's really looking more like epigenetic changes.
And just one more thing, and I'm not saying there aren't mutations that lead to these things, but I got really excited when I heard about the Human Genome Project a few years ago, and I was part of the CDC task force on public health genetics. And what we were expecting to come out of the mapping of the human genome was that we would see all these really mutations that cause a large percentage of a lot of public health problems, and that has clearly not happened. So I think the fact that that project hasn't led us to identifying specific changes in the DNA code that account for large proportions of public health problems, I think would also support what we're talking about, what Charney is saying, that there may be other things that really look like mutations that are really operationalized through epigenetics.
So one more question for Dr. Anda. There is one.
I'm taking a justice class and we talk a lot about theories. If you guys take a look at any theories that might back up, I know you look at facts, like these are the environments that the kids are exposed to, this is what happens. But if you take a look at any theories, because some theories might say that we talked about human beings are more predisposed to doing bad things, not necessarily being influenced by anything. Or there was another one that talked about the fact that they're blank slates and there are certain things that make them do what they do. So did you look at any theories, or did you just base your research like specifically on these are the facts that we gathered from these theories?
You're gonna have to repeat the question. I wear hearing aids, so I'm gonna let my
no,
colleague here repeat the question.
Standing up, so.
My question is that we did a lot of research in my justice class that kind of talked about theories and how human beings behave based on their theories. So we talked about how human beings are either blank slates that are easily influenced by certain things. So I guess the kids can be influenced by whatever environment they're in. And we also talked about the fact that they're not blank slates and they are just born with predisposed aspects of being, whatever it is that they end up to be. So did you look at any theories that have been put forth before, or was this research just based specifically on just the facts?
Well, that's really, I've never had that question before. That's a really interesting question. I think that in large measure that our experience really shapes the way that we think and behave and relate to other people, and that it's how our neural networks learn through experience and shape our behavior. Of course there are some people that are probably born with certain tendencies to have their neural networks wire up a certain way, but I would put myself more on the side of experience being a shaper of those kind of behaviors. There's a really good book on dissociative disorders. A colleague of mine in Atlanta wrote it a couple years ago, and in the first chapter she wrote something that really struck me. She said, "The self is built." Now, we used to think of the self as something that you're born with, that you come into the world with, and then you have this self thing inside of you that appears as you grow up. And what she says, studying people with dissociative disorders, is that the self, the way we behave, and the way we think about ourselves and other people, gets built into us by nature of our experience and the way we wire up through experience.
Are you speaking anywhere else before you leave town?
Pardon me?
Are you speaking anywhere else before you leave town?
I'm going to be at 1 o'clock tonight. I'm going to be out.
This is tooth.
No, this is my last engagement.
You guys will get a chance to talk to Dr. Anda again or ask questions to Dr. Anda. I just want to give David and Elizabeth a chance to talk about what's going on in Alaska, and then we can have Dr. Anda come back up, or there will be opportunity. We're supposed to go to 8, so we still got nearly an hour. So we've worked him over pretty good. This is like the 5th time he's spoken today, with or without slides. So David, you want to come up?
I could do that.
Does this thing? Does this thing work?
Yep. It works. Yep. Up here or down there? All right.
Can I just stay here?
Whatever.
One of the things that I was really looking forward to hearing was some discussion of interdisciplinary approaches for ACEs. And so if you don't mind, Dr. Anda, what I would like to do is kind of play a little, toss and catch here as it relates specifically to some of the components of my presentation. Just to introduce myself very briefly, my name is David Driscoll, and I direct the Institute for Circumpolar Health Studies here at UAA. And this is an interesting social experiment, having a group of researchers talk without their slides. This is the first time I've done that in over a decade. So it's really interesting. But I will say that if you could imagine the very best slides you've ever seen in a presentation, mine are like 10 times better than that. So let me I'll start off by talking very briefly. I've had an opportunity to actually see Dr. Anda's presentation a couple of times today. And so I had an opportunity to go back to my office and write down a few thoughts as it relates to interdisciplinary approaches, and specifically how that might approach the way that we could do something here in Alaska. And one of the things that I wanted to start with was the concept of diffusion of innovations theory. What we are talking about here when we talk about ACEs is really a new type of concept. Strangely enough, it seems really intuitive to us, of course, as we think about it. But the research that Dr. Anda and Dr. Felitti have conducted were actually conducted over the course of the last decade and a half, 2 decades. And as a consequence, as you might imagine, it takes a while for people to begin to understand and implement these kinds of conceptual and paradigmatic changes in how they approach their practice, and how they approach their research, and how they approach their educational processes. And so in large part, for those of you who are students here today, this really represents an amazing opportunity for you. This is a new paradigm. It's a new way to see a huge number of problems, and thus a new way to address them, and perhaps to intervene upon them. And so as we talk here, I hope that you're thinking about how it is that, if you were interested, you might engage with this, and how you might move forward in your own educational processes and in your own professional lives. One of the basic aspects of diffusion of innovation has to do with the concept of acceptance or rejection of a new concept. And it's been applied to a number of different public health practices over time. It was applied to the concept of fluoridation in water. It was applied to the concept of having people use seatbelts. And it helps to explain why it is that some people do things and some people don't do things, and why some evidently great ideas never actually, reach generalizability across a society. And there are 2 basic components to any concept in order for it to be successful, in order for it to be accepted by the general population and implemented in any kind of policy or program or intervention. And the first one really has to do with whether or not it's intuitively measurable. So whether if you tell someone, if you start using, if there is fluoride in your water, your children would have fewer cavities. If people in your household started wearing seatbelts, they wouldn't be as hurt if you had an accident. As you can imagine, that's fairly intuitively measurable. People can talk about that. They can think about what happened to their neighbors or their own family, and there's a way to test it. And so there has to be that component. There has to be a metric or a set of metrics by which you can assess the actual presence or absence of a specific concept. And then secondly, it has to be actionable. In other words, people have to be able to do it in the lived environment in which they are making their lives. It has to be something that people can implement effectively without having to change everything in terms of how it is they approach their day-to-day schedule. And I'd like to talk very briefly about both of those, and then perhaps toss it to you as it relates to the interdisciplinary nature of how it is that we might consider these things. Does that sound okay?
Sure.
Okay, great. So let's start, if we could, with measurable. Now, you provided for us, in a fantastic way without slides, these 10 general metrics that you've developed. And they dealt with, just to kind of go back and reiterate, they dealt with things like childhood emotional abuse, sexual abuse, physical abuse, substance abuse in the family, mental illness, and whether or not someone in the family was incarcerated. Have I missed one?
Domestic violence.
Domestic violence? Okay.
And neglect, emotional or physical neglect.
Okay, thank you. Now those are all, of course, extraordinarily important and unfortunately very prevalent here in Alaska. But one of the things that the ICHS, that my institute was involved in a relatively tangential fashion, was a study funded by the Alaska Native Tribal Health Consortium to look at the presence of other stressors in Alaska communities, and specifically in this case, Alaska Native communities. And Jim mentioned one of them, the concept of historical trauma. Nearly 20% of our population are Alaska Native or American Indian. And it may not be, it's probably not something that you were aware of, but up until relatively recently, many members of the Alaska Native community were removed from their home communities and put in boarding schools. And even before that, there was just a whole host of stressors associated with colonialism. When we pulled together a committee, an expert panel of Alaska Native leaders, they pointed to a whole host of issues associated with historical trauma that they felt would have to be assessed if you really wanted to try and understand adverse childhood experiences in Alaska Native communities, which in many cases are both geographically and to some extent socially isolated across the landscape in Alaska. There would have to be some additions, perhaps, to this module, to these metrics, in order to really understand them. Things that would look at, for example, whether or not someone in the household had been removed to live in a boarding school, whether or not models of parenting had been disrupted as a consequence of the fact that children didn't have an opportunity to see how a mom or a dad is supposed to act in that community. Things like whether or not they were exposed to a culture of violence in the boarding schools, such that when they returned to their community, that's what they knew. And there were a number of others. I'll just touch on them very briefly. Issues regarding environmental exposures to contaminants and other types of pollutants. Dietary stressors associated with having to change one's traditional dietary practices. Community violence, in many cases, that tend to reduce the amount of trust that one has in one's leadership. These are all categories of analysis, but let me just touch very briefly on units of analysis. I noticed that in the actual ACEs module, most of the discussion focuses on households. But in many Alaska Native communities, households aren't the only unit involved in raising a child. And so if you're going to look at potential exposures to adverse childhood experiences, is there a way, I guess what I'm asking here, is there a way to try and incorporate some of these additional measures in a survey or in some sort of a clinical situation that would allow us to really assess the prevalence of these additional stressors?
Yeah, and I think the answer to that is of course, yes. You know, what we did when we designed this in the 90s, we were thinking more in terms of kind of household or intrafamilial types of experiences. You know, we didn't, you know, we weren't smart enough in 1991 to think about the wider array of types of experiences. But you know, now there are groups that are expanding the universe of adverse childhood experiences to things that may be different in different cultures, in different communities. In Philadelphia, the Robert Wood Johnson Foundation has funded a group to take a look at things that are specific to inner city communities where there's a lot of poverty. You know, things like being not safe walking to school, seeing other people shot or injured or robbed, community violence, lack of community safety, lack of safety in the schools, a variety of exposures like that. The World Health Organization is looking at adverse childhood experiences in multiple countries. And the researchers that took a look at the way that we did things thought that it was useful, but that they needed to add certain things depending upon the cultures they come from. Things like forced marriage, slavery, human trafficking, living in a combat zone or a war zone, being dislocated, living in camps. So the universe of adverse childhood experiences is potentially quite large, and depending you're talking about the experience of tribal populations, that there may be a whole set of experiences that are equally important, or if not more important than some of the ones we studied, or that potentially may lead to an increased prevalence and sustaining of the kind of categories of exposure that we looked at. I think an issue that comes up frequently in this discussion is the issue of poverty. My personal belief is that that adverse childhood experiences of all sorts are a pathway into poverty, because they lead to difficulties with alcohol and drug abuse, maintaining relationships, criminal behavior, difficulty doing a job, being unemployed, and that adverse childhood experiences of all sorts are a pathway into poverty, and that poverty, being a traumatic or negative experience itself, sustains it, and so that the arrows leading to some of these things go in both directions. Right. So I don't know whether that's part of what you thought about with tribal populations, but which arrows, what's the directionality of where these types of traumatic experiences come from, and are they mutually reinforcing or self-sustaining? That's one of my beliefs about. My personal belief, based upon looking at data, is that poverty tends to be self-sustaining because of the sustained adversity and the developmental consequences of the adversity that leads people into it, and the conditions that add on to the ones that led them there.
Thank you.
And how do you think of that? I mean, since I'm not all that familiar with the tribal communities in terms of historical trauma or structural kind of issues in society, and how those relate to kind of the types of things that we studied.
So I was under orders by the dean to try and open this up for discussion. So if I could, I would ask members of our community to speak to that issue. Are there any other issues or any other categories that we should know about or talk about?
I'd like to add something. I think we often think of poverty as something that is just a matter of what happens in a community. There's always going to be those who are impoverished and those who are in different other economic situations that are probably better than that. But I'm suggesting here that we have federal and state governments who impose, in my opinion, poverty on some of our tribes through the regulation of fish and game and restricting traditional access. And it's becoming more and more prevalent over the last 20, 30 years. So, and then there's this situation of 40% native incarceration rate in Alaska, when David said we had 20% in our population. And also, those of you who work in the child care industry, you know that about 60% or better of children who are in the foster care system are Alaska Native children. So there's a hidden dimension here. When you get removed from your family, or if you get put in a situation like incarceration, it's also taking you away from the traditional things you would normally do for your community and for your family, and that is the ability to provide traditional foods, hunting, fishing, and gathering. And I think we often look at traumas as something in the past, but it's still with us in Alaska today that needs to be addressed in some fashion.
Another example that I've heard, that I've seen and read about and heard people talk about, and that are related to the kind of things that you're talking about, are policies and practice. For example, if you look at the war on drugs, and you look at incarceration rates, especially in African American communities, the incarceration rates that coincided with the war on the incarceration rates skyrocketed, and so what that did is it really disrupted the family structure, especially the loss of males to the families and communities, for nonviolent crimes, and so I think we need to look at big policies and practices that are traumatic to especially to specific populations as forms of adversity, as well as the kind of things that happen within families or within households.
So Alan is jumping out of his chair.
As you open up this whole Pandora's box, I guess, of adverse experiences, the question that rose to my mind is, what's the criteria for adverse enough? I mean, every experience can't be thought of as an adverse experience. It has to have some level of adversity associated with it. Could you provide some insights into how adverse these things have to be?
Well, I can't give you a definite answer to how adverse they have to be. I think what the data show is that the types of things that we measured are, on average, in the aggregate, they're adverse enough to increase the risk of things like alcohol and drug abuse 5, 6, 7, or 8-fold, and to lead to measures of attributable risk that are 50% or higher. So there's enough in the aggregate. Those types of adversity are great enough to increase population risk. I think the difficulty comes in when you try to apply aggregate risk of types of adversity at the individual level. I think you get into that kind of discussion, it's very difficult, because this is really more, it's more that this type of risk is more kind of a public health way of thinking about types of experiences or exposures that lead to population risk. Applying population risk or aggregate risk to individuals can get really confusing and dicey. So I think that's why I think these kind of things lead us to thinking about major policy and practice that can shift the population level of exposure to these types of categories of adversity and reduce the prevalence of those types of adversity. So it's really more of a public health model than how it affects one person versus another. And there may be a saturation point where if you're exposed to enough things that evoke the stress response, I think you asked the question earlier, do things flatten out? Is there a plateau point? And there may be a plateau point in certain communities where you can't, they've been stressed so much that you can't increase the risk anymore in the aggregate level than is already there.
I think the other thing I was going to say is that it's a self-report. So they, if the person thought it was adverse enough to indicate that it happened to him or her, then it was adverse. So according to the person, I don't think they didn't ask for intensity or what the level of adversity was. It was more or less, did it happen? And I think what Dr. Hand is saying about the aggregate makes some sense as well. Jim?
Let me just say just one more thing, since I didn't have my slides. Is that the biologic plausibility for toxic stress or adversity leading to the kind of outcomes that we looked at is really pretty compelling, because the neuroscience community is taking a look at differences in brain structure and function related to the types of categories of adversity that we studied, and they're seeing differences in brain volume and different structures, and in the way the brain operates in terms of communication. So the biologic plausibility, getting back to your idea of adversity, is that my belief is that if it's stressful enough to affect brain function or organ system function, that's substantial adversity. that it has to have biologic impact in order for us to measure it as an outcome.
So Jim,
Yeah.
and then this.
So I have a question for David, perhaps a follow-up. So the work ICHS was doing, were you looking at individual level indicators or population and community level? Were you trying to, like an adverse community
Yes,
experience?
that's right.
So this notion of taking this up to a community level, do you have any thoughts on that?
Taking it up to, so in other words, the unit of analysis wouldn't be an individual, it might be the community or the social context in which that individual was raised.
I think you can do both. You know, you can look at at community level risk or the differences between communities and historic, structural, political problems or other problems that occur in communities, and where the community is the unit of analysis. I think that maybe in some ways that's where the state of Washington is going. They're using communities as the unit of analysis to say how healthy is this community and how does that ecologically correlate with other types of things that may happen that affect human development. Yeah.
So Jim, a follow-up and then this.
So it just seems to me that at the community level, your kind of obvious suspects for the indicators would need to be made more granular. Is that correct? I mean, take poverty as a construct. It's multifaceted. I don't think looking at poverty would tell you much. You'd have to kind of tease it apart to figure out what the actual components of poverty are. Is that your experience?
So I think what we're talking about here is something referred to as the social determinants of health. And much of the work that's taken place as it relates to population health and social determinants has been focusing on trying to tweeze out these different levels of determinants. So you can have medial, distal, proximate determinants. And when you're using granularity in the same way, I think they might use distance. So in Alaska, many of the social determinants of health are fairly granular. I mean, we can identify specific attributes of communities or social settings and say, you know, to what is the specific, for example, for those of you from the Justice Center, what's the crime rate here? You know, what are some of the issues as it relates to people's experiences with the justice system? Those are good social determinants of health. If you have a very high level of engagement with the justice system across the community, then you can be fairly confident that there's something going on in that community that's troubled. And so, but of course, further back, a more distal determinant of health might be poverty. You know, you would look at, okay, well, what's the SES within this community? And of course, if we were really interested in trying to identify specific, and really where I was going with that question was, if we were to come up with an instrument, it would have to be actionable. We would have to be able to put it in operation in community settings. Mm-hmm. So it couldn't look like the phone book, right? It would have to be something fairly discrete, something that people would be willing to fill out. And so there's going to have to be some sort of a prioritization exercise that takes place. And I was interested in how you came up with yours. And it sounds like what you did was really kind of based on your own knowledge and experience, perhaps some theory. But you had to come up with something initially to test it at Kaiser Permanente. And that's what you and Dr. Felitti developed were these 10 metrics.
Yeah, the 10 measures that we chose, the reason we chose some of those measures is because there were national efforts at prevention of most of those categories of experience, like prevention of child abuse, prevention of child neglect, treatment or reduction of the amount of mental illness and substance abuse. So one of the reasons that was a major determinant of the categories of experience that we chose, that there were national programs attempting to reduce those kind of levels of experience in human populations.
So thank you.
Yeah.
Well, I come from a lens of early childhood policy development and data as well. So I'm going to go back to some of the references that were made earlier here to the early childhood relationships, and also just to talk a little bit about looking at the individual symptoms and dosage and response. That I think it's more important to go back to the relationships that are paramount in those communities and that multidisciplinary the importance of that multidisciplinary approach with education, health, policymakers at the state level, that coming together in those community fashions or at the state level or district levels or whatever we deem is helpful in terms of how we define that community is probably a little bit more important than looking at the individual symptoms, although I think
when I go back to what we talked about here today, if we're going to look at that, then that family unit is so critical, and that when what you have worked with is the earliest early childhood experiences, and so that's really important to come back and focus on and not lose that. I also wondered if you had heard of anyone that is working within that family structure, because I had read about the ACEs study used with adolescents as well as adults, but to work with it in the family unit, if anyone's doing that right now, with working with the parents as well as the children, their offspring.
I'm not aware of that being done, but as I travel now, I'm talking more with primary care providers about trying to bring this kind of cumulative stress, adversity, childhood adversity paradigm into the medical home, and looking at intergenerational care, because our primary care tends not to be intergenerational. We tend to treat the adults and the adolescents and the elderly and the infants and the young kids as different units, when in fact they're interacting together and the risk is being transmitted between them. I think we're at the time where probably there's some locations where that kind of way of doing things may be ready to be piloted. I know in Iowa I've had discussions there with a group called Iowa Health, where the primary care providers may be willing to start looking at some of these childhood experience exposures in adults and find out whether or not there's evidence that they were affected by them, specifically substance abuse and mental health, and then looking at the health and well-being of spouses and family members, and trying to find out, kind of in a way, kind of harvest those who have been affected, and to try to engage the families where these experiences have been transmitted from parents to adults and where the children are affected, and to treat and to begin to think of the family unit as an at-risk unit collectively. I think that's what you're talking about.
Right,
Yeah. That's a whole new way of doing business in terms of healthcare, in terms of primary care. I think it's doable, but it needs to be piloted.
So we'll take one more question, and then we're going to have Elizabeth talk about things from a community and philanthropic perspective. Go ahead.
Well, Dr. Anda, I've never heard you speak in person, but I feel like I know you because I've watched the videos.
Okay.
The cavalcade productions before you had a beard, right? And the more recent one. And I want to tell people that if you Google ACE study, you get a wealth of resources. And I get emails every few days now from ACEs Too High, which is a wonderful networking group that's going on. There's the ACEs Connection. I keep waiting for the ACE study's website to be updated because it's saying it's going to be updated.
Yeah.
But I have seen your slides, and they're very compelling. And you can see those slides if you go to the website and go to your papers, which are on there. They're very compelling slides. I lost my train of thought. I guess, oh, no, I wanted to correct something I think that came out that was misunderstood, is that you can go to the website now and download a single sheet and check off in, 1 minute what your personal ACE score is. But the people who participated in this study, these 17,000 participants, filled out a very in-depth study. And many of the questions were listed like Likert scale questions, from never to sometimes to frequently. And so to qualify as an ACE, you had to be up here, where you repeatedly were physically injured by a parent or something like that. So there was a cutoff at which it's considered serious. I think if your mother, if your father ever took a knife to your mother, or a gun, that was automatic, right? That was an ACE. But there were lower levels also that were considered domestic violence. So I think the study really did a good job at figuring out what an ACE was an ACE. And any contact sexual abuse was counted as an ACE. But not just if someone exposed themselves to you. It had to be contact sexual abuse. So my question is, fetal alcohol syndrome, fetal alcohol effects for all of you. Have you tried to integrate that at all into this whole story?
No.
I know there's work taking place attempting to do that in the state, but it hasn't taken place at my institute. And let me just, I should draw this to a close so that Elizabeth has a chance to tell us all about where the money's going to come from. But let me just close by saying that I didn't have a chance to talk about all the things that are taking place here in the state, but we've had an opportunity to hear a number of people speak who are associated with many of the really interesting programs associated with ACEs. Of course, the state of Alaska is very involved, and we heard some people attending a panel session this morning that represented a whole number of departments of the state interested in applying ACEs. We will be incorporating ACEs questions into the Behavioral Risk Factor Surveillance System questionnaire starting next year in Alaska, which is a telephone survey conducted of Alaskan residents funded by CDC. There's some really great programs taking place at South Central Foundation that are focused on ACEs, and a number of other tribal corporations. I know Chugachmute is also incorporating some ACEs components in some of the programs that they're running. What I think is probably missing right now is some sort of an overarching strategic plan that draws these pieces together. And when we look at the second of the two components of a successful diffused innovation, it's the actionability, how easy it is to implement this concept. And I think that's where we're struggling right now. And for those of you who are studying, for those of you who are looking at moving into a profession, this is where you can really make an impact, is looking at where are the gaps and how can I help? How can I assist in filling those gaps? Because ultimately, I think that the evidence is there, certainly. But to the extent that we can actually implement something that allows us to identify and intervene on ACEs, that's really where, the coin hasn't dropped. And that's where there are a lot of opportunities. So thank you very much for your time, and I look forward to learning about the funding.
Thank you, David. And our next speaker is Elizabeth Ripley. Elizabeth's the CEO of the Matsu Health Foundation. And she has a wealth of knowledge not only about Matsu, but about policy development, working in communities, and what role philanthropy can play in addressing ACEs. So Elizabeth, thank you.
Thanks. Just a little bit about the Matsu Health Foundation. We're actually a nonprofit hospital. We own part of Matsu Regional Medical Center with an equity partner and share governance of our local hospital. And so we receive our share of the revenues from our hospital, and we invest those back into the community in the form of grants to improve the health of our community. Our goal is to be the healthiest borough in the nation. So, we are kind of rooted in the clinical model, literally. And our acute care system is based on you being sick and diseased, and we come and treat you. And so that's really, I think that's often the framework that our systems work on. When we talk about health reform, that's part of the dynamics of health reform, is how do we build health instead of disease? We're paying for, healing disease. My exposure to ACEs has come through many different sources, and I think that I see a lot of different conversations going on. But one more thing on the disease piece. We're doing a community health assessment in Matsu. So we are doing an assessment of all the available data, and also including some primary data collection from our citizens to understand and sort of to benchmark how healthy we are. And so we can then hopefully implement programs or fund programs that improve the health status over time. And then we are going to go through a community engagement process in 2013 where the community has a chance to really take a look at this data and give us feedback and participate in prioritizing. Where should we really intervene? How can we, where are we ready to make a difference? And so we did an exercise with our board recently. What do you think the community's going to say? What do you think the areas that they're going to say? Obesity was number one. Substance abuse was number two. And
ACEs actually made number 3, which was like, well, that. So there were enough people. This was 14 board members that actually heard about ACEs that actually have it make the list. But those are still, most of them, downstream, right? We're downstream. So in the philanthropic world, when we talk about all these systems and how do we make a difference on the ground, how would it really improve the health of our population? What would it look like if we went upstream? What would be different? And we have a chance, I think, with some long-term funding sources to think a little bit more long-term about how we might affect those changes. And one way to do that is to change the conversation. Health reform is a good example. When you see how people are framing, for instance, well, your health is your personal responsibility. It's all based on your personal responsibility. I mean, that's a way we're framing the conversation about health. And yet the public health model has shown us that we can map health by zip code, and that your health is largely determined by your environment and context. And so how do then we create healthy space, healthy families, healthy homes that create healthy individuals? And so, there's a lot of, so how do we change the conversation to talk about the right things so that we can actually impact the health of our population? And I think there's a lot of movement in Alaska right now around ACEs in terms of changing that conversation, which I think is really, really positive. So just the fact that the state has found the funding and the will to implement the ACEs module on the behavioral risk factor surveillance system starting in 2013 is like a huge step. I mean, and a number of us have gone to Walla Walla to study what they've done there in Washington, and that's one of the first things they did was they used the ACEs module for the BRFIS to benchmark where they were. There are, I know the Alaska Mental Health Trust, United Way, Mental Health Foundation, state. There's a lot of conversations going on about how would this change things, and our thoughts. And there's lots of little convenings, and so we have been very siloed, okay, in our approach and our systems. Another example I'll use is I've been involved and helped start our local substance abuse prevention coalition in Matsu years ago, and we've got this great group of stakeholders, and we're working on substance abuse over here, and over here we have this great group of stakeholders, and they're working on domestic violence. And we've got a group over here, and a phenomenal group of stakeholders, and they're working on child abuse. And it was kind of revelatory, really, in the last 2 years to go, wow, you really can't talk about one of these issues without talking about all of them. And yet we weren't. In reality, we weren't, and our systems weren't either. So we're all working separately on these issues that are all tied together. And so we have to find a way to break down those barriers at the systems level. And these are built in. We've built them in. And of course, funding has helped keep them that way. Because lots of times the funding is siloed. Well, this funding only goes to substance abuse. It only goes to intervention, or it only goes to prevention. This only goes to... And so how do we change those pieces of our system, which are largely derived by policy and decision makers? How do we change how we allocate the resources, and also come together on the epidemiology side? Because we're not just doing the silo thing on funding; we're doing it on the we've done it on the research side. So how do we kind of bring it together and have a different conversation, and better allocate those resources? And maybe we have to do it incrementally. So we talked, a group of us got to visit with Dr. Anda today and talk about, well, what has worked elsewhere and what would it look like? And one of the things, a common theme, is that there's just a tremendous saturation of the information within the community, within all of within the decision makers, for the providers, but also for the general public and for families. So, you are fortunate to have received this information tonight. But in Alaska, while there have been a few presentations, Dr. Folletti was here, I think, a year ago, March, and I was fortunate to be able to hear him speak. There's really not that many people that know about this work, this study. But and even nationally, we just see it's becoming more and more prevalent in terms of the conversation. So what other, in other areas, what they've done is they've done a massive public relations campaign, for lack of a better word, at the professional level with providers, through having professionals come and give the information. But then in Walla Walla, they did a train the trainer model. And Walla Walla, the size of the city, as if I recall correctly, was about 50,000 people. And Mat-Su has 90,000 in an area the size of West Virginia. But probably in our core area, we're easily 50, 60,000, the same size as Walla Walla. Really, pretty easily. They did 400 presentations in 7 months on the ACEs information. And they did it, so for instance, they had one in-service day where everyone in their school district, from the bus drivers to the teachers to the administrators, were educated on ACEs and the brain development and the neurobiology side of what happens. And so a huge piece, I think that, I think it's going to be natural for us to look at in terms of funding is to how can we make these conversations happen through all of our systems. So just using the school system as an example, my husband's an administrator at Wasilla High, and he easily spends half of his day dealing with significant social and emotional and behavioral issues. One day, I'll give you an example, he kept getting paged that there was this young man in my class, I've never seen him before, I don't know who he is, could you come see? It took him, but he kept jumping from classroom to classroom. My husband finally tracked him down. He was having an emotional breakdown. He didn't even go to Wasilla High. He wasn't even a Wasilla High student. My husband had to spend the entire day with this kid who didn't even go to that school, and ended up taking him to the emergency department. And I mean, it was just, so we are allocating resources. My husband was trained to be a math teacher and an administrator. He spent an entire day with a student who didn't go to Wasilla High, dealing with emotional behavioral issues. And all of our systems are working like that. So there's a lot of frustration. And this trauma, the notion of trauma-informed. What if all the teachers at Wasilla High were trauma-informed? How would they interact differently in the classroom? How would they run the school differently? If all of our doctors in the emergency department were trauma-informed, how would they respond to their patients differently? They're not. They're not trauma-informed. And we're not unique. We're normal. Our workforce, we were talking about this today, our workforce likely has the same rate of trauma as our patients. So in this room, we'd probably find similar results to your study if we took the ACEs. Mm-hmm. Is that correct? Probably?
Yes.
So,
if not higher. Everywhere, in every audience where I've done that, the ACE scores of the audience have been higher than the ACE scores that we saw in the Kaiser Health Fund.
So we are that workforce taking care of or teaching or interacting with, right, the public. So, and I think ultimately what we want to do with this resource allocation is really move up. When I say move upstream, how do we prevent the adverse child experience? So it goes beyond, I mean, obviously that trauma-informed is a huge piece, but we want to intervene early. A lot of people have talked about relationship and family support. If our daycare providers were trauma-informed and they could recognize the trauma sooner, and we could intervene with the family and provide support sooner and rebuild a healthy relationship, what would that look like down the road? And so how can we use the fund, and the private funding that we have, for instance, I mean, it's nothing. It's a drop in the bucket. The big funders are government, right? And the big systems that we have. So we want to be able to use our funding to leverage change and leverage really a different allocation of resources to this upstream model. But the place I think we have to really start is education. We have to really understand it. We have to make sure that all of these different systems, whether it's the medical community, the school systems, the justice system, that we're informed and And it is a new paradigm. I mean, it really is a different way of looking at the world. And then breaking down of all those silos. So it's not just our substance abuse coalition and our domestic violence coalition, but in reality, if we're not working together and we're not pooling resources differently and really looking at preventing these experiences, we're still working downstream. We're too late. And so it's not always a matter of funding either. All of you are now people who can share this message and educate and teach people about this. And sometimes, lots of times, funding's not the answer. It really is about building the social support. So when you go upstream and you want to strengthen those relationships and you want to prevent that, I mean, a lot of the research that's being done out there really shows that the stronger the social fabric in the community, the stronger the connections, the more healthy they are. Because again, they're connected. They're looking out for that child. They have a reason. They're not disconnected. And so how can we build those connections? And that can be done, but it's not necessarily about money either. It's not necessarily about funding it. It's really about how do we look at our relationships with each other, about the children in our own neighborhood, in our own homes, but also in our own neighborhood, in our schools, and how can we help create better, healthier environments so they thrive.
Can you comment on the term social capital, or the concept of social capital?
We were fortunate to hear, I think it was Louis Feldstein speak, who co-authored Bowling Alone with Robert Putnam, and they have done a lot of research. And their definition of social capital ranged. It was quite a range. It included, your propensity to vote, to that connectedness and relationship piece. But the higher the social capital in a community, the higher the health status, the higher the graduation rates, the lower the crime rates. Again, I don't think, once you've seen the ACEs and you see there's a lot of commonalities in some of these concepts. But again, where are we investing? We're investing downstream. And it's going to be hard to change because we're going to protect, we protect the system the way it's built, where our jobs are, right? Where what we know. Well, this is how we do it. This is how we educate kids, right? And so it's hard to break out of those molds and have a different level of conversation, a different level of honesty, but then a different level of being intentional about applying those resources to build that connectedness and social capital.
Thanks, Elizabeth. Questions or comments for Elizabeth? Yes, go ahead.
I want to back up a little bit to kind of frame the question here. In addition to being one of those middle or upper middle class white males with a high ACE score and being personally worried about dying somehow early, I'm also a concerned voter and follower of things, and we've been sort of blessed in this election season with more healthcare discussion. And when I look at where there is money out there in a limited financial resource environment and where we could redirect resources, what comes to mind for me is this perhaps mistaken path that we went down in the medical profession at earlier and earlier disease detection rather than prevention of disease in the first place. And I'm wondering if from a kind of a piloting study project with small local things with a limited capital that you can raise at the community level, or through some sort of national influence, either as a voter or an evangelist or a picketer with a sign, what can we do to redirect at the national policy level or at the congressional funding level some existing resources that are really not going to ever solve some of these long-term problems and get them reallocated to a place where we can start to maybe educate, click it or ticket, 55 Saves Lives. Those are 20-year programs where we focused on the same message to make a change. And I know this is very early, for ACE type of information, but how can we as voters and just John Q. public try to help redirect those resources to the right place?
So who wants to start? Elizabeth, you want to take a crack at it?
Well, I know Dr. Anda talked today about in some places what they've done, education forums with the legislators where they made it clear up front they weren't going to ask for money, but they wanted to teach, have a forum to share this information. But I mean, I think where we have to start is getting a critical mass of people understanding the information, because information is power. People will change, systems will start to change if enough people understand the concepts. So it's my understanding that Dr. Folletti talked a year ago, March, and there were people in the crowd from Division of Juvenile Justice, and that they made some significant changes in our DJJ system based on hearing him speak. And that's without anyone asking them to, pushing them to, so I think you're going to see some of that. You're going to see some of that happen. And I think one of the other things that we need to do as funders is shine a light where we see it working and help connect people. So where we see it working, I know one of Bill's ideas today was, you called it an ACEs study group or support group nationwide, where
a users group.
Users group, that's what it was. So if there's pockets of people doing this work, well, what if we met, quarterly and shared, and so you help learn what's working, what's not working, and disseminate and connect people that otherwise might not be connected. And we can do that in our own state. You mentioned a number of things, David, that are happening. So, how can we shine a light on where it's working and get people connected to those? So
Robin?
One of the things that makes me think about, I know David thinks about research, and I'm not a researcher so much, but immediately I think about our students on campus. We have nursing students, social worker, clinical psychologists, allied health, so many different health workers, pre-med, PA. It seems as though we could come up with a curriculum that we could embed in all of our coursework so that our students would have similar experiences. And I know we're talking about interdisciplinary, but this is just such a great thought. So my question is, are you familiar with any universities in the lower 48 or other, maybe international, that have looked at a model curriculum in order to bring this to a university setting, in addition to your public education? Or just Dr. Andrew?
I think that's, Rob, you want to take that? Try?
I'm not aware of any as yet. There may be some, but I've not seen one. So you may be the first. And I think it's really a great idea, and an important thing to do in terms of the idea of reaching critical mass. If all the people in a culture can't talk the same language using the same concepts, then it's hard to generate the kind of large movement that we're talking about. And in terms of your question about being a voter, I imagine a time when the general public knows enough about this that they will ask questions of people who are being elected about what are you doing to move things towards the prevention end, and do you understand what the major determinants of health and social problems are, and what are you going to do about it? And that I think that's a low-hanging fruit of education, of educating the public, and especially educating students now, the next generation of people that are going to be tackling these things, because this is going to be a long haul. And I also think it's important to recognize a couple of things, that we're not going to make this go away, but because more stress is worse, more toxic stress is worse, if we can incrementally reduce the aggregate from the public health model, reduce the aggregate level of stress in the population, that I think that will be chipping away at the proportion of people that have the outcomes related to it. And the other thing that it took us a while to realize is that we need to be careful about differentiating between primary prevention and secondary prevention and treatment, because treating people with these kind of things they transmit to their kids and making them function better is primary prevention for the children they interact with. And so it's going to be both.
So I have a quick response as well to your question, which is a really good one. The first one would be that I feel like change is more implementable at the local level, because the community with whom you work and the stakeholders of which you're aware are going to be more amenable to discussions and to potential development of policies such as the ones we've heard about in Walla Walla. So act locally if you can. But secondly, and specifically as it relates to some of the programs and policies that you might see implemented at the federal level, it occurs to me that there is a movement afoot in both the research field, but also in terms of education and healthcare, toward a more participatory model in which members of the populations themselves have an opportunity to participate in the development of the objectives and the processes by which those objectives are carried out. And ultimately, when you talk about ACEs, or you talk about any other type of research or educational component that deals specifically with a social or physical contextual factor, members of communities intuitively understand that. And so I feel that as we continue to move toward more of a participatory model, and I feel like that should be something that we should be advocating for, then it'll become more intuitive that focusing on factors that are upstream are more likely to take place than would take place if you asked a medical specialist what they should be focusing on. So by working locally and by advocating for a more participatory model to research and to education seems like two good strategies.
Any other comments or questions before we stop? Yes?
Do you recall the name of the book you referenced earlier?
The name of a book that I read?
Right, one of your colleagues, a woman wrote it about dissociative disorder?
Oh, no, I don't remember the title. See if I can remember the author. Give me a minute, and if I remember the author, you can look up the author.
Okay.
Any other questions or comments? Yeah, one more.
I'm just a big one for maternal and child health. You know, it's just, you get so much bang for your buck. For every dollar you put in, you get more money back, right? So if we're going upstream, I think that's where we're going to end up, right? And the nurse-family partnership has, as I understand it, the best record in terms of dealing with these issues. So I know people want to go home, but people will investigate this idea of pairing women when they're pregnant with their first child with a nurse who in the first 2 years does 64 visits to that home and reduces child abuse by almost half.
That's a good point. All right, I want to thank, let's thank the panelists.